Assalamu alaikum. Good evening, everyone. Thank you for the organizing committee for this opportunity. I know my talk is the last talk, so I'll try to make it short and sweet. No more of graph or tables, and we'll go through it quickly and try to answer the uncertainties and questions regarding for young and low risk TAVI versus SAVR. So in my presentation, I'll be shuffling between TAVR and SAVR just to highlight the points where surgery has shown to be the prominent intervention for aortic valve replacement. So I don't have, So I have no disclosure. So in our presentation, we'll go through comparing the outcome between TAVR and the SAVR in low-risk cohorts and review the procedural complications, short and mid-term outcome, as well as durability, which is the mainstay, as well as discuss patient selection, surgical implication, knowledge gaps. And we see that from the previous presentation, which was done nicely, shows all the RCTs, shows that all the patient mean age above 73, 74, and when they try to have it lower in Notion 2, they reduce it by 2 years, by 72, 71. So we should be careful for exploitation that RCT data from older patient into younger population. So why surgeons should care? Because the referral patterns and the case volume shifting. We used to have that aortic stenosis, predominantly surgical option for the patient. There is no other options. But evolving with the industry and regarding for transcatheter approach and evolving with the partner trial, whereas those patients who deemed not to be surgical candidate or just for medical therapy, they have a new option where they can be treated with the transcatheter approach, prolong their survival, and improve the quality. So that's started first and started to expand it in more higher risk surgical patient, and now medium risk, then low risk. So that surgeons should care about that and should be vigilant about it. Management of complex anatomy and TAVR failure remains a surgical domain. So whenever a patient goes for TAVR, it doesn't mean that if he fails, there is always should be a surgical backup. So we should be aware about that. And the critical role of the heart team decision-making and procedural backup. So what's the limitation and uncertainties? Many of the long-term data, and as we saw in the previous presentation, when they talked about the first 30-day, 1 year, up to 5 years, it all shows results between the TAVR and the SAVR are similar, but however, there is no actual longer-term RCT trials. However, the 10-year observational or registry studies, not randomized, would that have an inherent bias, either confounding or selection. And the duration remains relatively limited, given the lifetime of the replaced valve, especially in the younger population. TAVR device technology, as we see in the TAVR and the partner and Evolved and the Notion, it's always different technology being used in those RCTs. And during the RCTs, there's a new technology evolving. So using the same technology when using the RCT or the newer devices also needs to be looked at. Patient population as an RCT, as we saw before, is always older, higher risk, and exploring that in younger and low risk, we should remain uncertain and should be looked vigorously and with scrutiny. So, when we look at the evidence landscape for the RCTs, looking at the Barton 3 and Evolved, favorable early outcome, registry, data set shows broader real-world performance. However, both those guide the practice and the policy. Barton 3, it's a balloon expandable, lower composite endpoint at 1 year. Also in the Evolved, the same thing. And it's a selecting population. As we saw, it's only in the patients with 73, 74, and the mean age of those patients. And it's still within 3 to 5 years. They don't have longer, 10, 15 years. So when we look at the procedure success. So newer valve, usually with the TAVR, always we hear about the valve that in first generation using Parthenon, then Parthenon 2 and 3. It's always evolving in their valve user, evolving in the technology, where they improve the sealing and low profile. That's result in reducing the paravalvular regurg. Transfemoral access, where usually use, previously we start to have thoracotomy for bigger valve. Now all goes through transfemoral with evolving technology. So what's the surgeon role here? It's the hybrid OR, where the surgeon take a role with the cardiologist in the OR, bail out sternotomy in case of failure, and the complex access management with a small femoral access. So when you look at 30-day mortality, we compare both of them, often comparable, but TAVR may have more advantage against SAVR. Many registries shows non-inferior 1-year survival. That's what shows in partners, trials, evolute. TAVR advantage, lower bleeding, shorter length of stay. When we look at that, SAVR advantage is lower moderate, severe paravalvular, and lower pacemaker, permanent pacemaker rate. Stroke, still, it's comparable between the TAVR and the SAVR. However, pre-procedural technique is very paramount, and anatomy influence the risk. And we need to be about the embolic protection devices. There is a mixed evidence that's used for clinical stroke reduction. For the pacemaker, permanent pacemaker, it's higher and shown in TAVR, even in Partner 3 and Evolve. And what's the predictor could be the pre-existing right bundle branch block, deep implant, membrane septum anatomy, and it's associated with length of stay and potential long-term LV dysfunction. Paravalvular regurg, one of the major thing or drawback on the TAVR, it's less common in the surgical group. And it's been shown it's associated with worse survival for the patient who developed moderate to severe paravalvular regurg. So when we look at the meta-analysis of randomized trials, more than almost 8,000 patients, with a mean follow-up up to 6 years, TAVR have higher rate of permanent pacemaker implantation and moderate to severe paravalvular leak. So other complication or other thing we would look at is bleeding and transfusion. Significant lower in TAVR was very obvious because it's a transcatheter approach compared to with the SAVR, which is important benefit for elderly or frail patients. Acute kidney injury, it's more favorable in TAVR than SAVR. And the length of the stay and the recovery and the quality of life, although it shows that TAVR have a shorter length of stay, patient quality of life and return to activities quicker. However, within a few months, within up to 6 months to 1 year, both group reported the same quality of life improvement, and there is no difference between them. Reintervention or valve-in-valve is feasible for the bioprosthesis, and a surgical explant following a TAVR, it's not that easy as being seen, 1 surgery lifetime versus 2 surgeries. It's actually associated with higher preoperative mortality and complication to explant a TAVI, as well as for the coronary access. This is one of the things that in the TAVI patients, when you plant, you should have a height of coronary at least 1 centimeter, because if you have it less than that, you might embedding the left main, and that might cause a problem to the patient. And going for valve-in-valve might not be feasible in the future due to that problem. So when we look at the midterm, it's encouraging, to be honest, between the TAVI and the SAVR. But you have to bear in mind that when you look at the patient above 70 is not lower than that, so we should be careful in our conclusions. Surgical bioprosthesis is being established with a longer durability, 15 plus, up to 20 years. So when you look at the 5-year pooled analysis of low-risk patients, usually around, I think I have
2 minutes, please.
still have more minutes.
Can we get the presentation back?
Okay, so I'll try to finish it. So midterm, we said that is very encouraging for the TAVR versus SAVR. However, the long-term durability here was the gold mine, which shows that follow-up more than 5 years shows significant higher all-cause mortality in the TAVR versus SAVR. A large meta-analysis, when we have more than 21 observational, almost 40,000 patients show higher all-cause mortality in TAVR over long follow-up, as well as in the low risk, as well worse survival in the low-risk patient, which suggests that the TAVR midterm advantage may reverse over time. So why that happening? For few reasons. So yeah, another consideration is bicuspid aortic valve. This is a unique congenital anomaly. That's patients who's younger with aortic pathology, usually bicuspid, compared to the trileaflet in the elderly, where all the studies shows benefit for the TAVI in elderly patients. So in bicuspid and younger population, I believe SAVR remains preferred mode of treatment. So when we look at the hemodynamics and clinical outcome in the low risk, although the RCTs demonstrate non-inferiority of the TAVR to SAVR in the short and the midterm, patients who have a longer life expectancy still premature to explore that TAVR could be. Can we have more than 2 minutes?
Okay.
So
just 1 minute. Okay.
I think I'll jump a few slides to. Yeah. So I'll try to go to. So the practical I'll go to the practical surgical implication that SAVR. So take-away message. So SAVR remains the standard for younger, low-risk, anatomically complex patients. TAVR is still valuable. I will not discourage that, but long-term evidence still evolving. Still, we don't have a solid data that will favor TAVR over SAVR. SAVR offers unmatched durability, precision, and comprehensive treatment capabilities. We should be having a balance in terms of short-term benefits with long-term durability and uncertainties in young patients. Surgeon must remain engaged in heart team decision planning and complication management. Thank you.